And just forward backward with this.
Yes, sir.
So as I said, I'm Dr. Bill Sterrett. I'm with the Vail-Summit Orthopedics and Neurosurgery. I've been practicing here in Vail for 20 plus years. Fortunately, I've had the experience to be the head team physician for the U.S. Women's Alpine Ski Team for the last 20 years, and that includes the last 4 Olympics and I think 11 World Championships. Fortunately or unfortunately, I've had a lot of experience with these women getting hurt on the hill, getting hurt off the hill, and trying to figure out how we can modify that and get them back as quick as they can. So let's just run through some of these things. This is what we're going to talk about tonight. Do women really have a higher injury rate in all sports? What's the data behind that? And we'll go through some of the anatomical factors leading to higher injury rates, and then some of the performance factors, which get into more of the modifiable factors, and then some of the differing treatment plans that Matt will go through based on some of these risk factors. Some of these are modifiable, some of them are just not. It's the way the different shapes of men and women. So there's absolutely nothing in this talk that you need to remember. There's not going to be any quizzes. It's just some take-home messages. If you need copies of this, we can always get it to you. But hopefully you can take something away that you'll use downstream in your life. This is just a picture of me at the Sochi Olympics. It was impressive. We had these armed guards every 100 yards or so escorting us, and they were super friendly, yet they had the automatic rifles with them. So let's just take an example that's not knee related. Let's talk about concussions among alpine and freestyle skiers. Over 7 World Cup seasons, we looked at how many concussions there were. And unfortunately, there was a much higher incidence in women than men. And there's a lot of speculation and postulations about why that might be. But it was about a 1.5 times higher concussion rate in our female athletes, meaning alpine racers, freestyle skiers, mogul skiers. And that was across all 3 disciplines, including snowboard. So you can ask down the line when we're into the chat session, could this be a reporting issue that women were more likely to report? Are there anatomical reasons why women are more susceptible to concussion? Do they bounce back quicker, slower? All of these things are great discussion points. We're mostly going to talk about knee injuries and how they specifically relate to women versus men. So depending on the sport, women are at a much higher risk to sustain a season-ending injury. So we used to talk 20 years ago about these being career-ending injuries. Now we're at the point where we're talking about season-ending injuries and getting back. And hopefully we're going to get to the point with some of the biologics and things that they're not even going to be season-ending injuries. But that's where we are right now. So let's just use ACL tears as an example that are typically season-ending injuries for almost any sport. True in the NFL, true in the NBA. But looking at this basketball, if we just assign the male injury rate as 1, females in basketball have a 3.5 times higher rate of tearing their ACL than the guys do. That's pretty astronomical. The volleyball players have about a 3 times higher injury rate or ACL tear rate. Soccer players 4 times, and then recreational skiing 6 times higher in our women than our men. And that's true in my clinic and practice. We take care of a lot of volleyball players, basketball players, soccer players, and especially recreational skiers. And invariably, you'll see a lot of the recreational skiers, 40-year-old women that have almost no fall and end up tearing their ACL. World Cup skiing, it's been interesting. We've looked at it high and low, and right now it's about equal men versus women in World Cup skiing. And a lot of that has to do with both men and women are going right on the edge and going as fast and as hard as they can. But I believe that there's probably an injury rate difference with the men versus the women in Alpine, the World Cup level, but that's the data we have so far. So then we looked at time loss injuries on the World Cup circuit, and that's all injuries. And a time loss means anything where you missed practice, training, or a race. And so in alpine skiing, 30%, which is astronomical, have time loss injury per season. That means almost 1/3 of our athletes are going to lose some time during the season from an injury. And in snowboarding, it's even higher, almost 40%. And that's a big, big deal. So how do we break this down a little bit further? The French alpine ski team looked at this over many years. overall ACL injury rate, almost 30% of men and the equivalent number of women sustained at least one ACL tear in their career. ACL injured racers had an almost 40% risk of sustaining another ACL tear during their career. So they're not out of the woods just tearing their ACL. Men and women racers had similar injury rates that we went through before. The World Cup ski racing is about the only sport with similar ACL injury rates in females and males. So again, on the French Alpine team, you look at about a 20%, 1 in 5, re-rupturing the ACL on the same knee. So you get your ACL fixed, you go through 6 months of rehab, sometimes even longer, get them back, and 1 in 5 are gonna re-tear. That's a huge, huge deal. And hopefully during the course of the night, we're gonna learn why that might be and some of the modifiable things we're trying to drive that 20% down as far as we can. But there's also greater than 30% incidence of tearing the ACL on the opposite knee. So you get your knee reconstructed, it protects you from some of the ACL injuries, but you're still at risk on the other knee. So, and then the mean number of surgeries on all of these athletes after they've had their ACL fixed was almost 2.5. So you get your ACL fixed, you're not out of the woods. Even if you don't tear your ACL again, you might tear your meniscus or have a cartilage damage or an MCL tear requiring surgery. So higher ACL injury rate, re-injury rate, and bilateral injury rate in racers that are ranked in the top 30 in the world. So it's even higher than this 19% and 30%. So all of our Michaela Schifrin's, Lindsey Vaughn's, Peekaboo Streets over the years, and some of our best racers, that's why we see so many of these injuries. You're ranked in the top 30, super high injury rate. Competitive female athletes, that's kind of the world I've been living in. So you have some spectacular athletes, spectacular injuries, but you also have spectacular failures when they come back and get re-injured. And we're going to go through why female athletes are more likely than males to suffer these ACL injuries. So let's talk risk factors. The anatomical risk factors, we're going to break this down into anatomical stuff, some biological stuff or physiological stuff, and then modifiable stuff or training things. And those are where we can really help our athletes out. So women are born a little bit more knock-kneed than guys. If you look down at your knee, and you can do that right now, when you look down, and if the foot goes out a little bit, that's knock-kneed, or what we call valgus. Women are about 3 or 4 degrees more knock-kneed than men. And we're going to go through why that's such a big deal. Hyperlaxity is much more common in females, meaning you're born loose jointed. And we all know somebody who can dislocate their shoulder. The things we look at are, I'll show you in a sec. You can move your thumb all the way down to touch your forearm. And we'll look at exactly what the definition of this hyperlaxity. So if you meet the criteria of being loose jointed, it's a much, much higher injury rate in tearing the ACL. Anatomical factors, if you look at this notch where the ACL goes, I don't know if you guys can see my little bullet here or my little pointer, that's the notch where the ACL goes. That's kind of a A-shaped frame groove in the bone inside the femur where the ACL goes. When that's in women, that's much narrower, usually about half as wide as the men, which can pinch the ACL, as you can imagine. The ACL in women for the exact same height and weight is about 30% smaller than men. That's a huge deal if you just think about it, and that's evolution right now. If in another 100,000 years, I bet they'll all be the same size, but when over evolution, the men were the hunters and gatherers and women were not, and now we're in a whole different ballgame. What's surprising and what really shocks a lot of our female athletes when I go through this is that the menstrual cycle has an important risk factor for you. There's a 3 times higher ACL injury rate during competition in the pre-ovulatory phase. So that first half of the cycle after you have your menses, that's when we see a much higher ACL injury rate. So when you go back looking at these athletes who tore their ACL, if we can go back where they were in their menstrual cycle, invariably it's in that first half of the cycle. So let's break these down individually, and we'll try to break this down in a not too scientific a manner. It's really interesting and really fascinating, but it can also get a little bit confusing or overwhelming. Feel free to throw questions at us down the line to ask more about this. So you can see on the left side of that picture, that's normal. being bow-legged is called varus. It's misspelled there as vargus, but being bow-legged, and you always think of cowboys being bow-legged. Knock-kneed is valgus, like that. And this can be developmental. You have your meniscus torn, taken out, and you can become more knock-kneed or bow-legged, but it's also congenital. Women are more knock-kneed than guys. Secondly, the women have a relatively wider pelvis, evolutionary-wise for childbearing, and that forces the knee to be in more valgus because the hips start out wider, so they got to come in and then go out again to be in neutral alignment. So knock-kneed athletes live with their ACL on stretch, whether it's a woman or a man. If you're knock-kneed, the ACL is just living on stretch, living as tight as it can be. So that makes valgus knees at a much higher risk of sustaining an injury to the ACL. So I promise you we talk about hyperlaxity, much like Gumby here. These are the criteria we look at, these 5 things, and everybody can do it on their own. If you put your, look at number 1, if you try to bend your pinky finger, and if it goes more than 90 degrees, you can see mine does not even close, maybe about 67 degrees. If it goes more than 90 degrees back, that's 1 point. If you can bend your thumb all the way down and touch your touch your forearm, that's point number 2. Point number 3, that's actually an elbow. If you can hyperextend your elbow 10 degrees or more. So straight is like that. If it actually hyperextends 10 degrees or more, that's another point. And then if the knee hyperextends 10 degrees or more, that's a 4th point. And then if you can bend over, touch your, put your palms flat on the ground when you're trying to touch your toes, that's a 5th point. By and large, without getting too much into the science of this, if you have 3 points or more, that means you are congenitally loose jointed. Those are the people that can dislocate their shoulders over and over. Those are the people that can dislocate their kneecaps when they're doing relatively minor athletics. But what we know for sure is that hyperlaxity of the knee, that hyperextension, is pinching that ACL on that narrow notch and gives it a much higher injury rate. So you ask how much higher? So you can see that that hyperextension of the knee, it can be in the order of 4 to 5 times higher injury rate to the ACL if you meet the criteria of being loose jointed. This is an example, just not an injured patient. This just shows how loose jointed some people are. And certainly women have a higher rate of being loose jointed than men. So athletes with a torn ACL were 4.5 times more likely to meet the criteria for being loose jointed than athletes that had not torn their ACL. The good news about loose jointed, because it sounds awful right now, is that they have a much lower risk of developing arthritis when they're older. So loose jointed people are the people that dislocate their shoulders, tear ACLs. When you know the 18-year-old female athlete that's been through 3 ACLs already, invariably they will meet the criteria for being loose jointed. Can't change that. You can't change being knock-kneed. You can't change being loose jointed. So some of the other risk factors, we talked about that intercondylar notch. This is just a graphic showing what a narrow notch does, and you can imagine how that might pinch the ACL, especially if the knee is twisting and it's already on stretch because you're valgus. And this is why it's such a big deal. Just like we talked about, the bone of the notch will pinch the ACL during twisting or hyperextension. So the male ACL, we talked about being larger than the female. So a 150-pound male who's 5'8" is going to have an ACL that's 30% larger than our females that are 150 pounds and 5'8". You got to believe that's going to change over time with how many athletes are playing sports, but it sure isn't that way now. And the menstrual cycle, we talked about the pre-ovulatory phase is right after the menses end, then the ovulatory phase, and then post-ovulatory phase. So the first 2 weeks after menses is when we're at the highest risk of tearing the ACL. It's in fact 3 times higher rate during that time. So ligaments are often more lax in general during the pre-ovulatory phase. Now, whether it's hormonal, because of all the hormones are changing during that pre-ovulatory phase and it loosens up ligaments, that's the best way to think about it. But in reality, there also might be, you're relatively anemic after the menses, you're weaker, More fatigue is a big factor at that point too, but it could be a lot of different factors going into that we just don't know. We do know that it happens though. So these are the factors predisposing women to season-ending injuries. And these are the things Matt's mostly going to talk about, these athletic factors. The two biggies are landing strategies. So looking at you from the side, you can see, and we did this about 15 years ago. In fact, Peekaboo Street was one of our athletes that we looked at jumping from a 60 centimeter box, so about 2 feet high, jumping and landing without any training. The women tended to land more straight-legged. The men tended to land more flexed. What we know is landing straight-legged, especially if you're loose-jointed in valgus and hyperextension, that's what's going to tear an ACL. So we see this a lot in volleyball, especially the outside hitters when they jump, hit, come down, land straight-legged, and they fall into that further valgus and they tear their ACL. So that's something that Matt's going to teach us how to train. The men tend to land more flex. You got a plantar flex, meaning point the toes down, land on the balls of the feet rather than flat-footed, and not straight-kneed. So that's going to pinch the ACL against the notch, especially if it's narrow and you're loose-jointed. Flex knee is going to be protective of the ACL. The dynamic valgus is the other thing that can be a little bit confusing and a little sciencey, but we'll see if we can get through on that. So looking at you from the front, if you jump, land, and the knee dives in from relative to the foot, that's called a dynamic valgus. So it's not the bony valgus we talked about or being knock-kneed. It's usually from weak glutes or other things that allow that knee to pop inward. So he's going to teach you ways to try to get that knee landing over the second toe when you're coming forward in a flex position. And that's one of the big things that we got to focus on. So if we can just figure out how to land flexed and not with that dynamic valgus, you're going to help protect our athletes so much better. And this is a little bit more dynamic. You want to land on the balls of your feet in a deeper squat, knees apart, and you can see that big X. Poor hip control, overuse of the knee muscles, ligaments, higher risk for ACL injury, stiffer landing with less bend in the knees, more inward collapsing in the knees. I think subconsciously, a lot of athletes are thinking, I got to protect my knee by landing straight-legged. That's the exact opposite of what you need. So pronation and foot things, which isn't going to be the focus of this talk, can also lead to this. So if you're hyperpronated, you're going to land with that dynamic valgus or extension, trying to protect that too. So the whole body, this whole kinetic chain has to be looked at, whether it's the gluteal muscles, pronation of the feet, whether you're born knock-kneed, things like that. So how can we start putting this all together? You know, it's everything. The increased Q angle, which means that valgus knee, having hormonal changes during the preovulatory phase, anatomical differences, meaning the smaller ACL, the narrow notch, slower reaction times in that preovulatory phase has definitely been shown. Poor landing mechanics and less power with this can all contribute. So you've got to be strong enough, and that's why we don't let our athletes get back skiing, playing basketball, playing volleyball until they have 100% of their strength back. That's when you're at risk. So these are all things, and you can tell looking at that, some of these are modifiable, some of them are not. And this is that landing on the right side. We'll have a couple of graphics of this just showing the right way and the wrong way to do it. So if you're a parent out there, please, please, please help us teach your daughters how to land correctly. There are a lot of guys that are landing incorrectly and are knock-kneed and hyperlax and things like that, and we can help them too. It just so happens that the women are a lot more hyperlax and valgus. When I did, every May we go out and do physicals on all the World Cup athletes and ski racers. A year ago we went out to Park City and did physicals on, and we had 17 women on the World Cup circuit. 15 of those 17 met the criteria for hyperlaxity, when in fact only 10% of the population should be. So there's something about being hyperlax that helps us be a better athlete, most likely, but it also puts at higher risk for these injuries. So these anatomical risks combined with some landing mechanics and dynamic factors are a big, big factor. You got to take into account the anatomical risks, but the modifiable things are the main thing we need to be able to focus on. So straight leg landing, knee dives in, foot everts or pronates. All of these things are the death nail to the ACL. And you can see that if you go to a volleyball practice in high school, you can see the athletes that are landing straight-legged. You can see the athletes that are landing in a little more flex position. Once you start paying attention to this, it's really amazing how much you see of the modifiable things. And it's an important thing to understand what's modifiable. So these can lead to anywhere between a 2 to 8 times higher season-ending ACL injury rate in our female athletes. The bottom line, loose jointed, knock-kneed athletes, poor landing mechanics are super high risk with cutting, jumping, twisting sports, male or female. And the combination of all three of these are just going to be a tough, tough thing. And I don't think we're ever going to be, because of the anatomical differences, I don't think we're ever going to be able to see equivalent rates between men and women and athletes, but we got to get closer, and we have the ability to get closer. So we're working on the problem. So for an ACL tear, for example, and I'll just get a little bit surgical on you, cadaver grafts for the ACL have an unacceptably high rate of re-rupture even in the first year in young athletic women. So some of the studies, the national studies that have been done by the Moon Study Group, for athletes under age 20 that had a cadaver graft had a 30% re-rupture rate in the first year. And these should be no more than 5% or 3 to 5%. Patellar tendon grafts, lower re-rupture rate, used to do nothing but patellar tendon grafts back in the 90s. Unfortunately, ski racers and jumping athletes, which are a lot of ours, are hesitant to go to the patellar tendon graft because it creates a higher risk of patellar tendonitis that can actually make you miss a whole year. We've had athletes, many athletes that you may know, that missed a whole extra year after their ACL solely because of patellar tendonitis. Overall, it's between 10 and 12% developing that patellar tendonitis. It's usually self-limiting and goes away after a year up to 2, but that's tough to tell an athlete. You got your strength back, you've got the ACL is fully mature and ready to go, but you can't ski race because of patellar tendonitis. Hamstring grafts, loved by ski racers because it's the least painful out of all these. Unfortunately, if you meet that criteria for hyperlaxity, the hamstring grafts have a 3.5 times higher re-rupture rate than using something from the front of the knee. So from the front of the knee, the two choices are patellar tendon grafts or quadriceps tendon grafts. So, and part of that reason, if we take one of the hamstrings from the back, it can actually contribute to increased hyperextension of the knee or hyperlaxity. So it's a great graft. They're all stronger than the old ACL, so it's not a matter of anymore of which is strongest. It's kind of the pros and cons and risks and benefits of each one. So we've been moving in these hyperlax female athletes, moving towards a quadriceps tendon graft to replace the ACL. I tend to use this as my graft of choice now for the hyperextenders and people that are going through it a second time or even third time. And it seems to not have that same risk of tendonitis. Goes from the front of the knee and doesn't lead to that hyperextension issue. So I'm going to be winding down here, turning over to Matt, but with more women playing sports, maybe this is all just evolution. What we see in guys over history is we're going from that, and now we're slouching and having back problems from sitting at a computer and desk, and what we see in women that they didn't used to be playing as many sports as they are, and now it's just a huge, huge benefit to our society that we have so many great women athletes out there. Unfortunately, we're dealing with a much, much higher injury rate problem. Some are modifiable, some are not. So with that, I think I'm going to turn it over to Matt. We need to think of and treat our female athletes different than we treat our men. So just because you tore your ACL, it's not necessarily just who's your doc, what graft did they do, things like that. There's a lot of things that go into it. If you're not loose jointed and you're 40, a cadaver graft or even a hamstring graft would be great. If you are pretty young, patellar tendon graft, quads grafts are both great. Hamstring if you're not loose jointed. So Matt, I hope you can teach them all so that we don't get any more female ACL tears, and then we'll open it up to questions.
Great. Thank you, Dr. Sterrett. Again, my name's Matt Mymern. I work at Howard Head Sports Medicine here in Vail. I've been fortunate enough to practice physical therapy for the last 14 years here in Vail and work with our U.S. women's alpine ski team for the majority of that time. So again, a lot of experience, good and bad, with dealing with female athletes in sports as we continue to grow and sports continue to improve and get faster and stronger, we have to look at every way possible to keep our athletes safe, especially of our female athletes. Just a quick reminder, pop those questions into the Q&A so we can get those answered at the end of this. So kind of take home points from what I want to give you today is kind of your injury reduction programs and then training specifics. So Dr. Sterrett did an excellent job going over the anatomical issues, the things that we cannot change. That's where PTs come into play. That's where we're going to thrive in teaching our athletes and our patients how to move better and how to function better. So we take a quick look at the research and say, what's out there? What are we doing that's working? What are we doing that's not working? So a basis of any of our programming has to rely on some things that we've worked on and done in the past. So looking at Army recruits, kind of a different type of research study, but it looks at exercise programming using a 15-minute regime 3 times a week and using strength exercises, flexibility exercises, and some sort of coordination exercises. This was matched against a placebo program, which just consisted of upper body exercise. The improvements were noted in the intervention group in their running distance. So yes, we made a change in something and we improved. It did not prevent any overuse injuries. So what was the key factor out of this research article is that there wasn't any neuromuscular exercises performed. And I'll get into what neuromuscular exercises are in a second here as we move forward. Taking a look at adolescent injury prevention in soccer players. So we illustrated earlier in the talk that female soccer players have a higher risk. This is one of those groups of athletes that we want to get in front of early on. So we looked at that pediatric population and a reduction of knee external rotation or moving your knee to the outside. Could we change something in that programming? So that's kind of that biomechanical factors. It was really unchanged in the youth population. And any of you, and most of you with children out there, small children, they move a little differently. They have a little bit different movement patterns that progress as they get older, and that's something we can look on. So kind of a key factor takeaway from that article is that it was more progressive, had a little bit more variety, but it allowed for some feedback, but didn't necessarily change it in adolescents or younger athletes. So then we look at a little bit more specific and went through a training program out of the University of Vermont Medical School, and their training program led to a 69% decrease in the number of knee injuries among the ski patrol and personnel that were ski instructors in Vermont. So the right type of training can be extremely beneficial for our athletes and our females and for everybody to move properly for the sports that they're working to. So then you start going down, what did they do? What can we build upon to keep our athletes safe? Perfect example in this article. So 844 female soccer players aged 14 to 18. That is a big group going forward, and that was matched with almost 2,000 age-matched controls. So we had an intervention group help to prevent injuries or what's called an enhancement performance program, and then a control group, which would be your normal workout before a soccer practice, some drills and whatnot. So what they found out after 1 year, there was an 88% reduction in ACL tears in the performance enhanced group. After 2 years, a 74% reduction. And we'd have to get into the depth of the article, but a lot of the times is as we start doing programming, we as athletes like to choose what we like to do versus what we want to do. So instruction and maintaining that is important. So huge difference. So we add in some enhanced performance programming versus a control group, and we can make some of these modifiable risk factors and reduce them. Last program, so what works best going forward? So this was a big systematic review, and that's taking all the collection of research that we know about, putting it all together and see what comes out. An enhanced sports metrics or prevention program was probably the best to that showed ACL decrease in injury. And what those included, they had all aspects of our strength and conditioning. So we had some sort of dynamic warm-up, so you're moving properly. You had some plyometrics jump training. You had strength training. You had flexibility. So you had all of these into one program with your core strength and upper body strength as well. So you created a big picture program for your athletes, which not only can potentially improve their performance, but look to decrease their risk. So we can, keep them out of the OR. What we need to add into these programmings and what we're looking for as PTs, as trainers or strength coaches or those that work directly with certain teams is what their core stability looks like, what the neuromuscular control is, what their biomechanics and technique looks like, build on their plyometric programming, and then create that neuromuscular control that I alluded to. And I'm going to go into that a little bit more in depth here in a minute. And then look at their dryland training program and see where the holes are and see where we can improve what they're already doing and keep our athletes, especially our female athletes, as safe as they can training so that they can participate and not miss those season-ending injuries or just off training days where Dr. Sterrett mentioned 30% of those female athletes missed part of their season. So looking at your core stability, athletes who have a decreased core control of their core, measured during a kind of a trunk repositioning, had a sudden load increase, which distributes load differently into the lower extremity, which has a risk for that ACL injury. So we still have to think core stability in all of our exercise programming. So this is an example of a core stability exercise, a very upper level one, where you have someone sitting on a ball on their knees, tall kneel, and then moving their upper body with them. So I've got quite a few examples moving forward in this program so we can take a look exactly what we're working on and doing. We've got a lot of options as far as the exercises to be creative. The BOSU, that's the blue balance disc that's hard on one side, soft on the other. We can do a lot of core stability using that to keep our athletes and our patients engaged as well. So that's part of it. Hamstrings, as we talked about on loose jointed, hamstrings can play a role in your stability and your requirement, especially when you're landing, moving, jumping, cutting. We need to have your activation on your hamstrings. As we mentioned, ski athletes preferred a hamstring ACL graft because it didn't have some of the symptoms in the front of the knee, patellar tendonitis, but it also led to difficulty with hamstring activation, and we had to modify our programming with our patients with hamstring grafts to improve their hamstring strength and stability because some of it was used for the graft. So we have to take all of those considerations together and say, what kind of surgery did we have? What's modifiable in your risk factors? Are you loose jointed, hyperlax? What do we need to do to create a performance program and a rehab program to keep our athletes safe and get them back as safely and quickly as possible? So looking a little bit into the biomechanics of it. So closed kinetic chain or CKC versus open kinetic chain, OCK. What this is really feet on the ground is closed kinetic chain, and then foot off the ground is what your open kinetic chain. There's a difference between the forces generated between those two and the strain that's placed on the ACL. Just as we talked about earlier, if you have that valgus position, you're on that stretch a little bit on the ACL all the time. There's where we work on your biomechanics and your technique and say, what can we do to help these factors and change some muscle relationships or some muscle programming so that we don't have that tension and that stress building. If we have a strength difference and the valgus, there's another risk factor that we can see in the clinic. So glutes and hamstrings and core stability is weak. We have one leg stronger than the other for whatever reason. Those are Those are all risks for ACL injuries, and especially in the young female athletes. And those are things that we need to address, work on, and correct. So playing a quick little video of that valgus squat. So that's something that we were going to see in the clinic, and that's something we want to correct. We do not want our athletes training in this position, landing in that position, or moving forward, versus this one where we have a nice solid knee over the toes, good positioning, using glutes, using quads, and a much better technique. And I think all of us can agree that one is much better than the other. On the plyometric side of things, technical jargon for that, plyometrics is an activity that involves and capitalizes on the mechanics of the stretch shortening cycle to increase the efficiency of force production of a joint to increase performance. So how quickly and how efficiently can we create a muscle contraction? And that correlates a little bit into how far someone can jump or how fast someone can move. There's your plyometric activities. It's also a very demanding type of exercise. So we also need to be careful when we introduce plyometrics, especially in a post-surgical population. We want a nice slow progression of this. And plyometrics are also a way to recreate full sport motion in a controlled environment as close as we can. So think about it, going into a squat position and then quickly getting out of that squat, lifting the legs off the ground into a jump. And if you do it over and over again, there's where your plyometrics become very, very challenging. We talked about it earlier, dynamic stabilization. So what's the difference between plyometrics and dynamic stabilization? So looking at the decrease in the initial contact force and that valgus angle at the knee. So we need to increase that knee flexion upon landing so that we don't have that risk of that knock knee and that valgus contact force causing a problem. So looking at what the research suggests of using both plyometrics and balance training to help reduce those knee valgus angles. So we're retraining the movement pattern to land better, to move better, to be more efficient. And all this is relevant in the clinic or on the field or in the training room for our patients and our athletes alike, to use both plyometrics and balance training and some sort of core stability program to reduce the injuries that we're seeing. So we take that 8 times higher likelihood of an ACL tear in that female athlete, and maybe we can drop that down in half. Maybe we can make it even less. That is our ultimate goal, is to create an environment for our athletes that they can work well in and reduce their risk going forward. So looking at your plyometrics, like I said, you want to have a nice gradual increase in your intensity. So how fast or how much you're tolerating it. So if a tissue hasn't had a chance, like the ACL, to tolerate any sort of load, we need to be careful with it moving forward. The volume is something we consider. How many number of times does the foot hit the ground over and over again? And that depends on the experience level of the athlete or the patient. And then your recovery time on that. How much time between sets and reps, how hard it was, the intensity, fast, slow, did you give someone a break, all of that. It all goes into your recovery time between your sets. Progression, we want to sometimes start with the most demanding level, the hardest activity first, and then progress when someone starts to fatigue into something else or when form starts to deteriorate. Plyometric programs in general last anywhere from 6 to 15 weeks. And the reason we have such a good long span is to make sure that we've loaded all the tissues appropriately so that their best chance for no re-injury on playing soccer, playing volleyball, or on the ski hill is that we've tested almost every parameter of that athlete's ability, their jumping tolerance, their joint tolerance. We haven't overworked, we haven't over demanded anything from those athletes. So first picture here, easy box jump, and this is a much smaller, this isn't Peekaboo Street, so we used a smaller box. But we look at that straight knee, let me play that one more time, kind of more of that straight knee landing pattern where she kind of lands, knees are kind of locked and she's not really absorbing going forward. Second one. Looks at that knock knee landing position. And again, I think we can all agree that's probably not a good thing to keep working on. So that's something that we can do that takes 3 seconds to be able to screen an athlete or screen a patient and put them in a program and get them dialed to what they need to work on. And then after some training, we have a nice, good landing mechanics, bending the knees, landing, absorbing with the muscles so that you're using those big, powerful quads and landing appropriately so we're keeping our athletes at minimal risk in building and developing on those movement patterns. So I alluded to what neuromuscular control is. So this gets really scientific and tricky, so I'm going to keep it on a level that I understand as well. So this pertains to the muscle, the nerves, and the muscles. So coming out of our spinal cord, if we take a cross section of our spinal cord, a little sushi slice through it, it looks kind of like a butterfly. It's got nerve endings on both sides. Each one of those cords or nerve tracks send stimulus to our muscles and our nerve endings. So those are things that on neuromuscular control end of things that we can vary and challenge based on the patient or the athlete. So we can change surroundings, we can change vision demand and put someone in some, just for an easy example, sunglasses on a bright day changes their visual input, or we change the sound input or the decision making and have someone respond in a different way that they weren't expecting. All of those can improve our neuromuscular control and our demand, which can have potentially a very good carryover into their performance when they have a variable condition. It's the one thing in the clinic that we have a hard time controlling for sport is the actual sport decisions that you have to make. Soccer players having to make a rapid cut, volleyball players doing a quick motion to dive for the ball, skiers have to make last minute adjustments because of terrain, and they're at the probably hardest level because they have to deal with so many more variable factors on the ski hill, temperature, ice conditions, is it snowing, is it windy, how is the course lined up, equipment issues as well. So we're trying in the clinic also to make that is realistic, and that all goes under that neuromuscular control kind of window. So if we can enhance and improve the neuromuscular control, can we create a body system or a movement system that allows us to have the best chance at performance with the lowest injury risk? So we use this BOSU ball, standard. On my left side of the screen here, you add in what's called a body blade to it, and you increase the core demand doing the same type of exercise. So can we make a simple exercise more difficult? And early on in potentially rehab or training wise for younger athletes, we maybe start with the easier, and then we have something to progress to as well. Same, doing a little ball toss, looking right, looking left, changing the visual demand, making someone react to an object moving forward. So things that we can do in there. So sport specific, so we'll just focus on skiing since that's what we love and do the most. And we want to focus on our entire lower body. Your quads, hamstrings, and your glutes are the biggest muscle patterns that you really think of. So your thighs, the back of the leg, and your glutes. So what we can change is the type of surface we're using, the type of motion involved, the reaction time, the length of it, and then a warm-up. So how do we change the load? So this is a exercise with Michaela Schifrin with a weighted side lunge onto a different type of surface. So it's not a solid surface. So that allows her to have some feedback on what is under her feet, allows her to work on her form, her maintenance, and then she's carrying a load. So she's loading at the same time by doing the exercise. So we take a look at that, and we'll dovetail off of the surgical aspect of the first part of the talk, what we do when we return back to sports. So Dr. Sterrett did his part and performed the surgery. We're going through rehab, and then what do we do at the end? What do we do to get the athlete back on snow and safely? If we've organized our rehab properly, we've caught all the things that we need to work on. Our core strength, our lower body strength, we've improved upper body strength as well. We've regained fitness, all of those things. And then we want to test it, and we want to be able to test it in a controlled environment like the clinic so we can see if that athlete is ready for the demands of sport. So there's some movement patterns we can do. Functional movement screen is FMS testing. So that looks on how the person moves, and do we need to correct anything. The Vail Sport Test is something that we've developed a long time ago with the 84 ski team. So we can endurance and fatigue an athlete. Then we look at their balance, and then we look at how far they can jump. And then we have some ways to measure strength in the clinic and actually get numbers so we can compare right versus left and force output 100 versus 90 and see where we are. And then we look at those jump landing strategies or those plyometrics to say, are all those things looking the way we want them to? If they are, we're great. We send a report in, and we get the final okay from the surgeon, and says, Dr. Sterrett says, you look good. PT says you look good. Let's start getting back on the field and starting to go back to practice. So we want to look at all those things, and it's not necessarily return to competition. It's returning back to your sport. We want you to be back on grass, snow, the field for X amount of days, weeks prior to competing, so that we know that you're safe going forward. So what we can do on an ACL program is use that multi-phase progression and provide core stability. So we're working on that stability and movement at the same time, that dynamic stability, that balance, that proprioception, more of that upper level. Lower extremity strength and endurance. We start building strength and power and working on our endurance at the same time. And then we look at the plyometrics and agility, the speed, the cutting, the landing strategies. And for most of our patients, it's the last two bullets that are the entertaining ones or the fun ones. The first part of rehab or injury is never the fun part, but we're working and building back into that. Add in that neuromuscular training, surface changes, visual input, all of those good things, and we create a multifactorial dynamic program that encompasses everything that we know. We take into account all the risk factors that we know. The ones we can change, we're going to do our best to change them. The ones we can't change, we're going to do what we can to work around those changes and hopefully change movement patterns for the better. So we add those all together, and hopefully we're working on reducing those injury tears, especially in our female athletes, which have such a high rate, like we said, 30% or 8 times greater than their male counterparts. So we want to look out and provide a different level of care and treat our patients just slightly different, so that we can create a program that gets our athletes back on the field and playing and happy. Thank you, guys.
Thanks, Matt.
There's the Q&A. There we go.
Oh, great. Thanks, Matt. That was fantastic. I learned a lot too. Some of the decision making on getting back to sports is the hardest thing we do at the U.S. ski team. So I think, are we ready to take some Q&A? Yeah. Okay. Let's see what we got. Let's go. So I don't think doesn't look like we have too much going on right now. If anybody has any questions, just type them in. We're happy to talk. What we know about female athletes that it's all multifactorial. We're working on the problem every day. We'll probably do another one of these about biologics in sports medicine and surgery with the platelet-rich plasma and stem cells and everything else, trying to speed up Mother Nature, because that's where we are right now, is that we have to, our surgeries are getting minimally invasive and not hurting so much, but we have to wait for Mother Nature to heal everything up more than anything else. We thank you all for your participation. This is a lot of fun for us. We love doing a little teaching and educating. I think we've got a question from Carrie Pastrano that is asking Matt, how important is gluteus medius strengthening, and how can you, Matt, maybe you can also tell us about the gluteus medius and what it does.
Yeah, absolutely. Great question. So vital, the glute med is a vital strengthening, often overlooked or neglected because we can't necessarily see the atrophy. So if we have a knee injury, we can see our quads lose strength. We don't necessarily see our glute. The glute medius lies underneath the glute max. So it's a smaller portion of the gluteal region, and its main job is to provide stability for your leg during stance, and especially single leg stance. So we need a balance between glute strength, especially the glute med in stance phase. So when we're just standing, and then when we are on one leg. So in a rehab program, we would start glute strengthening as soon as the injury was ready for it, so that we're anticipating and preparing for it. So good question. It's part of that glute strengthening.
What would you do to strengthen your glute medius specifically?
So Dr. Sterrett asked, what would you specifically do? Early on, it would be a non-weight bearing exercise like a side-lying clam or side-lying leg lift. We've probably all seen a version of those. There's a couple different Pilates versions as well. Once we start able to load the knee, any type of single leg activity helps to strengthen your glute med because you're allowing it to stabilize while you're on that. So single leg stands, single leg squats, leg press with one leg, balance on one leg, and then we can vary the angles, surface, and kind of create that neuromuscular demand.
And is there a way to specifically strengthen the medius over gluteus maximus or gluteus minimus?
Yes, so Dr. Sterrett asked target muscling, target strengthening. So for the glutes, you can. So your glute max is a powerful muscle. That's your sprinter muscle or your takeoff muscle. The glute med is your stabilizer. So we have different types of exercises we can do for those. So the way we squat, the way we move, the type of exercise, and a cowboy squat or a sumo squat with the legs kind of pitched out at 45-degree angle is going to allow glute max and less glute med, and it all kind of goes with the line of attachment with the muscle. So we can target things. Also has to do on a deeper level of the nerve innervation, which those two muscles have a different nerve muscle pattern, so we can individually strengthen those. So good questions. Here's a good one.
So we have another question. Why is there an equal rate only in the World Cup? Is it possible the rate could be duplicated in recreational skiing? You know, I would think so, and that's certainly where we're trying to head to. It's hard to train recreational skiers with the appropriate jumping and landing patterns. It's easier for a college volleyball player, basketball player, or World Cup skier because they're under our control before they're out there competing. A recreational skier often is coming out without any real training, certainly don't go to a physical therapist before skiing typically. So I think it's possible, which is the question. And it's just going to be a little bit more difficult. Next question, is there data on ACL injury rates in postmenopausal athletes and recreational athletes? So let me answer that in a slightly different way. Because unfortunately, postmenopausal athletes, the 40-year-old female and above, have a high ACL injury rate. And part of that is because the ACL undergoes some changes in life. At the age 40, our ACL is only half as stiff and half as strong as it was at age 20. So much less of an injury might tear an ACL, and that has nothing to do with hormones. That's true for guys as well as women, whereas the quadriceps tendon, patellar tendon, hamstring tendon don't have that same age-related changes. So a better way to answer that is rather than postmenopausal, how about the people that we stabilize their hormones over the course of a month? And of course, we're talking about people on birth control pills. And so that's been looked at and shown to lessen the injury rate. Certainly it doesn't necessarily lessen the injury rate, it spreads it out over the course of the month, as you might expect. So that's where a lot of our athletes have gone to, is staying on the pill, whether they need it for other reasons or not, but just kind of stabilizing their hormonal, their monthly hormonal stuff. Next question by the same person: any data on the ACL Strong program in use by PSIA? Do you want to answer that, Matt?
Sure, absolutely.
That's a great question.
So very good question. So the ACL Strong program builds off of current research and literature that that I kind of stated earlier in the presentation. So it is a strengthening program that puts together strength, agility, core, and mechanics to help reduce those injury rates, especially in our skiers. The main problem with any strength program or reduction programming is getting the participant to complete the program. Just as Dr. Sterrett said, we have control over our World Cup athletes because they're in an organized setting. Most team sports are in an organized setting. When we start to venture off into the community and recreational, we can set the program in place, but we also need some feedback, whether that's periodic or by monitoring or video or whatnot, so that we can see if the participants are completing the exercises appropriately.
Well, one of the other answers to that, with ACL from Vermont, they showed us how to prevent injuries stepwise, trying to teach athletes how to fall in a different pattern that didn't, just like we're doing in the prehab phase with absorbing the load and not landing knock-kneed and valgus. They were teaching athletes more recreational skiers, how to fall when they ski, not getting their shoulders facing uphill, not reaching their hand back, not having the hyperflexed knee. And they showed a dramatic reduction, as Matt showed, in ski patrol, ski instructors, things like that. That was instituted actually by Vail for a period of time and a lot of other ski areas. Unfortunately, we weren't able to reproduce the results, and it was super labor intensive. So I think that hasn't been used as much as they used back in Stowe and other Vermont areas. Next question we had is, what is the best treatment for long-term or continuing patellar tendonitis? I'll answer that from a surgeon standpoint first, and then turn it over to more therapy with Matt. So tendonitis starts off as a reversible problem. You just get inflammation in a tendon. That's true for any tendon, and you got to decrease that inflammation. Rest, ice, anti-inflammatories, topical anti-inflammatories for the patellar tendon has worked very well for us. If this goes on long enough, then what we see on the MRI is that that inflammation, that fluid in the middle of the tendon actually takes over, and you see cells dying. And so you get this myxoid degeneration of the tendon. It's actually dead tendon in the middle of it. And that's really tough to treat from a therapy standpoint. So the MRI really helps us stage this. And oftentimes, once you get that dead tendon in the middle of it, you can do therapy till the cows come home, and until you get that dead tendon cut out, the jumping athletes really aren't going to get rid of that pain. So that's an important thing. So the real question, or the best question is, or answer for me is, long-term continuing patellar tendonitis when it's still in that reversible phase. Everything I know has to do with eccentric strength training being the cure or the best treatment for that. And eccentric just means, in case you don't know, it's if you're in the gym, it's negatives or reverses. So you're doing double leg squats, but you're doing it much slower going down, and not as fast coming up. That's a very non-scientific, that's the surgeon's answer for that, but I'll turn that over to Matt.
So yeah, one of probably the hardest therapy things to treat is long-term patellar tendonitis because has some anatomical or histological changes in the cell. On a perfect case scenario, if someone has patellar tendonitis or that anterior knee pain, we want them to come in immediately because we have a lot more options we can provide early on to be able to treat that. So whether it's exercise, training, putting in an eccentric programming, or some sort of modification in an exercise, or you're doing an exercise inappropriately or inaccurately, that's leading to it. So is there a cause? So that's probably the best way we can treat it from a clinical standpoint early on is what are we doing? Can we make this a change and can we do it early on? The long term, we have a lot more issues with treating on it because of that change that's already occurred, and that's really hard to treat.
So just back to me, my advice is if it's been going on a year or more, it's really worthwhile getting that MRI because you can go on to that dead tendon myxoid degeneration, which you don't want to keep burning time doing therapy that may not help. And actually that dead tendon can actually lead to partial rupturing, which is also a whole different treatment. Chronic tendonitis, also from a minimally surgical standpoint, patella in particular has been amenable to platelet-rich plasma injections. And we have a lot of people that are very good at that. So PRP has been a great treatment plan for that. I think we're probably going to have to sign off now pretty quick. We sure appreciate everybody taking an hour out of their day to come spend some time with us. We appreciate all the questions. If you have more questions, send them along our way. You can do it privately. We're always happy to answer. And I think this is just fun for us to talk about. If you have other topics you want us to talk about, send those along as well. Thanks so much for attending, everybody. We'll see you next time. Oh, we've got one. I'm going to let Matt answer one more question, and then we're going to have to go.
Okay. So I'm just going to move because I'm going to plug in this computer so I don't lose you. Okay, what is the recommended to treat an injury of the ischial muscle if an acute injury has become chronic since 6 months or more? So probably alluding to some sort of hamstring or glute injury. It depends a lot. So this 6 months or more is starting to become a chronic issue, as you just stated. We'd have to see what you're capable of and what your symptom set would be. So pain, what type of activity, and then put in some sort of conservative management. If that doesn't work, then we'd send you to the doctor's office to take a look and see what we can do. We always prefer conservative management first and see what we can do on a rehab level first and then go from there. So not the best answer, but that was a very specific question, hard to diagnose, but appreciate the questioning. And again, we're available. Contact, email for more direct questions, and we'd be happy to. I thank everybody for joining us tonight, and everybody have a good evening.